Okay, here's our 10-minute topic for today, which is seizures and epilepsy. What are seizures exactly? Well, they're abrupt, abnormal, excessive, and uncontrolled discharge of neurons in the brain, and they cause alterations in our level of consciousness or changes in motor or sensory ability or even behavior. Epilepsy is actually the medical disorder that is characterized by chronic, reoccurring, abnormal brain electrical activity, so chronic, reoccurring seizures. And then it's diagnosed as epilepsy. So what are the risk factors? Well, we can have a genetic predisposition, and especially absence seizures tend to occur in families. It can be caused by acute febrile state, and that's particularly seen among infants and children under the age of 2, which is why we want to keep fevers down. Head trauma. It can be an early or a late onset, up to 9 months after a head trauma. Seizure activity can happen, and increased incidence of seizure with skull fractures. So if the head trauma actually a skull fracture incurred, there's more likelihood for a seizure to happen. We will see it. A risk factor is also cerebral edema, especially when it occurs acutely, and the seizure activity tends to disappear when the edema is treated. If someone abruptly stops taking their anti-epileptic drugs, they're going to have the rebound activity of seizures. Infection, if it's intracranial, say as a result of increased intracranial pressure. If it's systemic infection, it can be because of that persistent febrile state, and then a seizure may occur. Metabolic disorders are also risk factors. Insufficient or excessive chemicals within the brain. We see that with hypoglycemia and hyponatremia. Seizures are a risk there. Exposures to toxins. Primarily, it's associated with rubber and tanning industries, and tanning not as in sun tanning, but in leather tanning. So that type of toxin that comes from leather tanning. Okay, here's our 10-minute topic. Okay, here's our 10-minute topic for today, which is seizures and epilepsy. What are seizures exactly? Well, they're abrupt, abnormal, excessive, and uncontrolled discharge of neurons in the brain, and they cause alterations in our level of consciousness or changes in motor or sensory ability or even behavior. Epilepsy is actually the medical disorder that is characterized by chronic, reoccurring, abnormal brain electrical activity, so chronic, reoccurring seizures. And then it's diagnosed as epilepsy. So what are the risk factors? Well, we can have a genetic predisposition, and especially absence seizures tend to occur in families. It can be caused by acute febrile state, and that's particularly seen among infants and children under the age of 2, which is why we want to keep fevers down. Head trauma. It can be an early or a late onset, up to 9 months after a head trauma. Seizure activity can happen, and increased incidence of seizure with skull fractures. So if the head trauma actually a skull fracture incurred, there's more likelihood for a seizure to happen. We will see it. A risk factor is also cerebral edema, especially when it occurs acutely, and the seizure activity tends to disappear when the edema is treated. If someone abruptly stops taking their anti-epileptic drugs, they're going to have the rebound activity of seizures. Infection, if it's intracranial, say as a result of increased intracranial pressure. If it's systemic infection, it can be because of that persistent febrile state, and then a seizure may occur. Metabolic disorders are also risk factors. Insufficient or excessive chemicals within the brain. We see that with hypoglycemia and hyponatremia. Seizures are are a risk there. Okay, so let's look at the types. Generalized seizure is also called a tonic-clonic seizure. We used to call them grand mal seizures. They can begin with an aura, which can be a smell or a vision or a feeling. So the individual will have an aura prior to the seizure. It usually begins with a 15 to 20 second tonic episode, and tonic means there's stiffening of the muscles and loss of consciousness. And then there would be a 1 to 2 minute clonic episode, and that's the rhythmic jerking of the extremities, and that follows the tonic episode. So it's tonic and then clonic. During the tonic phase, there can be irregular breathing, or the person may even stop breathing. And remember, that's only 15 to 20 seconds. But we can see cyanosis at that time. And then during the clonic phase, the individual may bite their cheek or their tongue with that rhythmic jerking that's going on. During tonic phase, there can be the tongue bite. There can also be incontinence that goes on during the seizure, and during the post-ictal phase, there can be, which is after the seizure. When it's over, it's called post-ictal. There can be a period of confusion or sleepiness. Plain tonic seizure, only the tonic phase is experienced, and once again, that's that stiffening. It only lasts a few seconds. There's no loss of consciousness, but it's much less common than a tonic-clonic seizure. Then we have just plain clonic seizures, and that's only the jerking. There's no fatigue after that type of seizure, and it's much less common than the tonic-clonic. So most often you're going to see both. The absent seizure is most common in children, and this is a loss of consciousness that's only a few seconds. Sometimes you'll see just this blank stare, and then they kind of come back. And then they come back to baseline as normal. There's no apparent sequela from the seizure activity itself, and those are called absent seizures. Now, there's the myoclonic seizure, and it's consistent of brief jerking or stiffening of the extremities, and that can be symmetrical or asymmetrical, so it can be on one side or both sides, and that can last for a few seconds. The atonic or akinetic seizure is few seconds of loss of muscle tone. So they fall, the patient falls or the individual falls, and then it's usually followed by a period of confusion. Then we have the partial or focal local seizure, and of those seizures, or that category, there's the complex partial seizure, and they've been associated with automatisms, where people are automatically doing something like lip smacking, or they pick at their clothes. They're not aware that they're doing it. They just might have this automatic lip smacking kind of thing that goes on. I'm sure that sounds great, but kind of that's what it sounds like. And there can be a actual loss of consciousness for several minutes with this, and an amnesia can occur prior to or right after the seizure, so they just don't remember it. Simple or partial seizures are consciousness. They stay awake throughout the entire time, and it can be like just unusual sensations, like a sense of deja vu or autonomic abnormalities, such a change in heart rate or abnormal flushing, unilateral abnormal extremity movement, or smell something offensive, or have a pain. These are really hard to pinpoint down. I can think of times when maybe I had a seizure, because you have a weird abnormal flushing or your heart rate changes. Is that a seizure? I know it's hard to classify that. And then finally, there's the unclassified or idiopathic seizures, and they don't fit into any of those categories I just went over, and they account for actually half of the seizures that we see. So it's for no unknown reason someone will have a seizure. So what are the lab tests? Well, when someone comes in having had a seizure, we're going to anticipate that they're going to do alcohol and illicit drug levels. They'll probably do HIV testing. They'll probably do a screening for toxins. Say they worked in a rubber factory or a leather tanning. They'll screen for toxins. They may order an EEG, an electroencephalogram, and that records the electrical activity. We're going to teach our patients who are going to have an EEG not to drink caffeine 6 to 9 hours prior to the procedure, wash their hair before the procedures but not to use any oils or sprays, and wash before the procedures but not to use oils or sprays, and after the procedure to remove the electro glue. So they can be asked to take deep breaths, or they might expose them to flashes of a strobe light during the procedure. They're trying to kind of elicit that weird abnormal activity while the patient has the EEG electrodes on them. They might also withhold sleep or keep the patient up prior to the test to or possibly actually have them sleep during the test. They're just trying to see the changes in the brain waves. MRIs are also done, CT scans, PET scans. They could do a CSF for analysis, maybe do a cranial x-ray to see if there has been any type of trauma, skull fracture. They just want to see what is the potential cause of the seizure. Okay, nursing care during a seizure. One of the very first seizures I ever saw, I was about 6 years old, and my mother, the nurse, had me shopping in Woolworths, and there was a man having a seizure on the floor in the lunch counter of Woolworths, and I can remember my mother stopping to help him and doing exactly this. She protected him from injury. She moved furniture out of his way. She actually held his head in her lap, and she turned him on his side in side-lying position. She was trying to decrease the risk of aspiration. So that's exactly what we want to do. We want to make sure they have a patent airway. We want to put them on their side, decrease aspiration, loosen their clothing. Do not attempt to restrain them. Protect the head from slamming against the ground. You can put them on your knee or a pillow under their head. If you are in a setting where you have suction, you may want to have suction available for oral secretions. And don't attempt to open the jaw or insert an airway during the activity. You can actually break their teeth. And don't use the padded tongue blades that we used to have. Just get rid of those things. They're useless. And during the onset and duration of the seizure, you want to make sure that you're watching very closely. You want to look for their level of consciousness. Were they apneic at all? Did they stop breathing? Is there any cyanosis? What was the motor activity? Did they have any incontinence during that seizure? After the seizure is over, put the patient in side-lying position because we want to prevent aspiration. We want to facilitate drainage of oral secretions. We're going to check their vital signs, look for any type of injury, do neuro checks. Patient needs to rest. Reorient them in a calm way. Calm them down. They might be agitated or confused. You want to put seizure precautions, implement seizure precautions. So if we are, there's a spelling error. Anyway, if we're in the hospital, we're going to pad the side rails. We're going to put the bed in low position. And we're going to put that on the chart that seizure precautions need to be observed. Ask the patient if they had any type of aura. And that can possibly indicate to the neurologist the indication of the origin of the seizure in the brain. And then see if there is any type of trigger. Are they fatigued? What brought it on? Was there a strobe light? Whatever. So what kind of medications do we use? We use anti-epileptic drugs. And the initial goal is to control that seizure activity. And then if that's not effective, they're going to try another one or increase the doses on those. Therapeutic levels are determined by blood tests, and that's done very routinely. With anti-epileptic medications, they need to be taken the same time every day for effectiveness. So that's a big patient teaching point. You want to make sure that they take their medication at the same time every day. A trick to teach them is to keep their pill bottle next to their toothbrush, because they typically we brush our teeth at the same time every day, and if it's a BID order, first thing in the morning and in the evening, typically if they take their pills right next to their toothbrush, they will take their meds at the same time. Want to make sure that we're aware of any drug-drug or drug-food interactions with the medication the patient's on. There's not a huge amount of allergies with anti-epileptics, yet they can happen, and it can occur right away or late in the therapy. So if the patient does develop an allergy, we're going to find something different, the physician is. Some anti-epileptic medications can cause oral gum overgrowth, so we want to get the patient to the dentist routinely and make sure they know that so that they have good oral hygiene. Now, specifically with Dilantin, which is one of our most common anti-epileptic drugs, we want to make sure that the patient knows that taking Dilantin and oral contraceptives, the Dilantin will decrease the effectiveness of the oral contraceptives, and therefore they might get pregnant. So it's not a good idea to be on the pill when you're taking Dilantin. Another one that you do not give with Dilantin is warfarin. It should never be given, or Coumadin. Coumadin, warfarin, whatever you want to call it, do not give it with Dilantin. Also, our patient teaching includes referring our patients to social services if they need to have help with paying for it. If they're in the school system, if they're children, they need to have the school aware of the situation, and whether or not they are able to drive, and that's a whole big bag of worms, so that is something that has to be checked into. Surgical interventions, there's vagal nerve stimulators that can be put into a portion of the brain where we see intractable seizures. That's an option for some people. There's another one where they will do surgical removal or interruption of brain tissue, and I actually knew a woman that had that done. She was a teenager at the time. It made a huge difference. Her intractable seizures quit. So that was very successful for her. So that's another type of intervention. So what do we need to tell our patients? Mostly is we need them to be compliant with their meds, to be aware of what their triggers are, to understand when they get an aura, to educate those around them about their seizures. And the complication of epilepsy is status epilepticus, and that's a prolonged seizure activity that's longer than 30 minutes in duration. And the complications of this are related to the decreased oxygen levels, so they become hypoxic, and there can be a loss of brain function, which can be permanent if someone goes into status epilepticus. So if that is occurring, we want to make sure that we do our ABCs. We have airway. We make sure the patient has oxygen. We're going to get an IV in them. EKG monitoring on pulse oximetry. Maybe do ABGs. Typically, we're going to see Valium given or Ativan, a loading dose of those, and then we'll do a continuous infusion of Dilantin. Dilantin given intravenously is not compatible with anything else. It needs to be in a tubing of its own and not piggybacked into anything. So that would be the urgent or emergent interventions for the nurse.